So the definition of chronic headache, so it refers to a headache experienced for more than 15 days per month for at least 3 consecutive months in the absence of a serious underlying medical condition. So that is the definition of chronic headache, which is agreed by the recent most consensus. So it should be present for more than 15 days per month for at least 3 consecutive months in the absence of a serious underlying medical condition. So you can appreciate serious conditions such as space-occupying lesions are not included within the definition of a chronic headache, but it needs careful evaluation and exclusion. So if you look at the prevalence of chronic headache, excluding those of acute headache, the prevalence ranges from 0.9% to 1.5% among school-age children. And as you grow old and among adults, the prevalence is threefold high, which means as you grow old and in your teenage years, the prevalence is likely to rise, and this is likely to be more problematic in the teenage years. The management of a chronic headache is often a challenge, and it's of 2 types. First thing is that you have to exclude a potential serious underlying cause. Although it is rare, a space-occupying lesion can present mimicking that of a chronic headache. So it needs thorough evaluation and exclusion before we diagnose chronic headache. And also, because it's so troublesome to the affected child as well as the family as a whole, we need to agree somehow on a robust management strategy to cope with distressing symptoms without being too much adherent on pain-relieving medications, because it can make you dependent on pain-relieving medications, and that also can be a trouble, and that can make your headache persisting despite being on medications, because you are likely to develop tolerance with time. So optimal management reduces the consequences like reduced quality of life, and when it comes to children's school refusal, sleep-related issues, and anxiety and depression. So if you look at the etiology of chronic headache, it can be classified as primary and secondary. So you call it primary chronic headache when you can't identify an underlying cause. For example, migraine, tension type headaches, cluster headaches, where you can't identify a specific primary cause and secondary cause, you can identify them as primary chronic headache, whereas secondary chronic headaches are related to some kind of an underlying medical etiology. For example, conditions like benign intracranial hypertension, Chiari malformation, or arteriovenous malformation, or venous sinus thrombosis. So they can present with chronic headache, but they are due to some kind of a different primary etiology. And most headaches in children are primary, so they belong to mostly to one of migraine or tension type headaches. And primary headaches are mostly episodic. For example, migraine, they come in episodes, and they come as acute recurrent episodes, but with time they can become more frequent and pervasive over a period of time, so that they can become chronic. So if we take the 2 common types of primary headache that are likely to become chronic are chronic migraine and chronic tension type headache. So both these types, tension type headache and migraine, though they can be acute and recurrent, they can transform into chronic headache. So that is a process of existing primary headaches increasing in frequency over times, so that subsequently they can become continuous. So they can become chronic by a headache transformation. So during this process, the child is unlikely to experience vague, non-specific symptoms, but it doesn't mean it is going to be less troublesome. So with time, it can be more troublesome with more persistence of these troublesome symptoms. And there are other types of chronic headaches such as medication overuse headaches or new daily persistent headaches, which I will be discussing in the coming slides. And also it's important to realize the clinical approach to a child with chronic headache does not depend on the type of the chronic headache, whether it be tension type or migraine. We have to follow common principles. The main thing is to rule out a possible secondary cause for headache so that the underlying etiology can be managed without delay. And also there is no guarantee that you have a primary headache as the primary diagnosis. Later on, surprisingly, child can be found to have found to have a secondary headache. So it's always important to be vigilant and important to arrange follow-up of these children and evaluate regularly so that accidentally if a child presents with a secondary headache, then you won't miss it. There are several headache red flags which we all have to keep in mind when evaluating a child with chronic headache. That is mainly to rule out a secondary cause of headache. For example, persistence of headache in a child less than 4 years. So headache, when it comes in a younger child, it's always concerning because migraines and tension type headaches are quite unusual in young children. And persistent headaches that awake the child from sleep or that occur on waking up, and associated symptoms like confusion or disorientation, change in the character of the headache, and change in the behavior of the child or the posture of the child, or headache that comes in association with persistent nausea and vomiting that is more prominent in mornings, and alarming neurological symptoms like deterioration of handwriting skills, clumsiness, change in hand preference, focal neurological signs like focal weakness, arrest in pubertal development, especially in teenagers, which may indicate underlying hydrocephalus or a space occupying lesion, or polyuria and presence of seizures, change in personality. So presence of one or more of them can indicate an underlying central nervous system pathology, ranging from a space occupying lesion to Chiari malformation to benign intracranial hypertension. So it's important to look for these red flags in all children presenting with chronic headache before we label them as having either tension type or migraine type of a chronic headache. And also it's important to do a complete neurological examination apart from taking a thorough history. And then we should focus on for the presence of cranial nerve abnormalities, any abnormalities in vision, presence of upper motor neuron signs, and problems regarding balance and coordination, and evidence of cerebellar dysfunction and presence of papilledema. So they again may represent an underlying central nervous system pathology for the chronic headache. So in assessment of a child with chronic headache, we have three main aims. One is to exclude, although rare, this rare presence of an intracranial space occupying lesion or a secondary cause, and then to determine the degree of problem, including how it is impacting on the functioning of the child and the family as a whole, and then to identify any precipitating factors or triggers, which is very useful in managing the child's condition. So those are the main aims of assessing a child with chronic headache. And also, once a space occupying lesion has been excluded after neuroimaging, we are mostly concerned about two other secondary causes that can explain chronic headache. For example, a child may have idiopathic intracranial hypertension, or a child may have Chiari 1 malformation. So both of them are can present with very indolent type of headache, which without focal neurological signs, and we should be careful not to miss them in a child presenting with chronic headache. And in the assessment of a child with chronic headache with the focus on idiopathic intracranial hypertension or Chiari malformation, we have to do a thorough neurological examination, including fundoscopy examination, because they are likely to show papilledema in fundus examination. But if our suspicion is high, despite the papilledema being absent, there is a place for doing magnetic resonance venography of the head in order to confirm the diagnosis, in order to suspect the diagnosis. However, the diagnosis is confirmed based on assessing the pressure within the central, cerebral spinal fluid pathway. And Chiari malformation is likely to be seen on neuroimaging because it's an embryological defect. And if it's the Chiari malformation, the referral should be made to the neurosurgeon. And if your diagnosis is BIH, then a referral to the neurologist needs to be made. So let's look at how to evaluate a child with chronic primary headache, keeping in mind of these most likely causes for chronic primary headache. So history is the cornerstone in evaluating a child with chronic headache. So we have to, this should be focused on ruling out a possible intracranial space occupying lesion. So we had to ask about the symptoms of the onset, the progression, and the transformation of the headache from the child as well as from the parents. And then we had to ask about the current management, including pharmacological and non-pharmacological therapies, and then the nature of the analgesic use and the risk of analgesic overuse. It's also very important to ask about. And then it's important to ask about how the child is coping with pain, usual trigger factors, usual relieving factors, the onset, the site, whether it's unilateral, bilateral, duration of the symptoms, associated symptoms, and also elicit any history of secondary gain, for example, removing the child from challenging situations so that child is likely to gain from that, and that will maintain the child's headache. And also assess the impact of headache on child, the family, the day-to-day functioning, schooling, and etc. And the social impact include the absenteeism from school, parents' time off from work, and missed recreational opportunities for child and the family, impact on relationships both within family as well as with peers, and effect on mood, appetite, weight, and sleep, and so on. So obtaining a thorough social history is also very important in evaluating a child with chronic headache. And lack of sleep in children can both be precipitating as well as maintaining chronic headache. So it's important to look at the child's sleep pattern, and then the usual behavior and the personality, any associated symptoms of psychiatric conditions, especially that of anxiety, panic episodes, and depression, and a family history of migraine, anxiety, or depression. And then also ask about any precipitating factors or trigger factors for child's chronic headache, whether the child is dependent on analgesics, suboptimal sleep, dietary factors, about skipping of meals, include especially the breakfast, and the exercise pattern. Sometimes over-exercising can precipitate migraine, use of caffeine, stressful life events, emotional abuse or stressful situations, psychiatric conditions, they all can precipitate a child's chronic headache, and it's worth looking at those risk factors. And also social history continuation, overscheduling of extracurricular activities, insufficient relaxation times, and safeguarding issues. And in physical examination, we should focus on performing a thorough neurological examination to rule out secondary causes. So complete neurological examination, and check the blood pressure, because high blood pressure also can be a cause of headache. Look for presence of neurocutaneous stigmata, features of tuberous sclerosis, neurofibromatosis, evidence of self-harm, because these children are likely to suffer from depression. The pain, the chronic pain can trigger symptoms of depression as well as depression. The headache can be a symptom of the depression or anxiety themselves. And look for evidence of non-accidental injury, especially in young children. Carefully examine the ENT, because ENT may have the primary focus of headache, and examine the dentition as well, because the pain can be of pain's origins can be in dentition, and get the anthropometric parameters, see whether the child is obese or not, because it's a risk factor for benign intracranial hypertension, and check OFC irrespective of the child's age, because hydrocephalus or intracranial pathology can result in occipital frontal circumference lying in higher centiles, or crossing or acceleration of occipital frontal circumference can be seen. And assess the pubertal status in teenagers if there is a pubertal arrest, so that can indicate an underlying hydrocephalus or intracranial pathology, and assess the patient's demeanor, mood, and engagement. So those are important in physical examination of a child with chronic headache. And investigations, so it depends on our history and the examination-based evaluation. It's not a must to do neuroimaging, but it's generally recommended that a child with chronic headache with no explanation warrant neuroimaging to rule out a space-occupying lesion. Therefore, the merits of neuroimaging in chronic headache should be considered on a case-by-case basis. And also, we have to keep in mind that the risk of over-investigation of chronic headache, for example, an arachnoid cyst of uncertain significance, sometimes can lead to significant parental anxiety, but it may not represent the underlying etiology for child's chronic headache. Therefore, it's very important to provide the right education to the parents with an acceptable explanation of the primary headache, coupled with a robust management plan. So let's look at a few causes of chronic headache. Migraine is the most common cause of chronic primary headache in children, and the diagnosis relies on the clinical features of the chronic headache. Compared to adults, children's, the migraine is rather frontal than temporal, and it's bilateral rather than unilateral. And it has a multifactorial etiology with a lot of trigger factors, as well as a family history of migraine evident. And also certain types of migraines, including hemiplegic migraine, have a clear genetic etiology. There are known genetic defects which are related to hemiplegic migraine. So the diagnosis, a child must have at least 5 attacks that fulfill these 5 diagnostic criteria. So duration of at least an hour to 72 hours, and usually unilateral in location, quality is pulsating, and moderate to severe in intensity, and it's aggravated by activity. So all these 5 criteria should be present. And also remember, in children, it can be bilateral rather than unilateral headache seen in teenagers and adults. And also, in addition to this, at least one of nausea, vomiting, photophobia, and phonophobia. So one of them also should be present for you to diagnose it as migraine. Treatment, mostly migraine is treated with non-pharmacological measures, mainly avoidance of trigger factors, and then ensuring the child's sleep hygiene is good, ensuring a good healthy diet, and having healthy exercise. And also you can try relaxation and biofeedback techniques. If you have vomiting during the period of aura, it can be managed with antiemetics. Medications, pain relieving medications of 2 types: abortive treatment and preventive treatment. So abortive treatment mainly include, in a ladder, you can take paracetamol, ibuprofen, naproxen, which are NSAIDs, and also severe episodes can be aborted using triptans, mainly sumatriptans. Preventative treatment, there are several agents which are useful. Propranolol can be used in children who do not have asthma or atopy. Amitriptyline is an antidepressant, can be used. Verapamil is a calcium channel blocker, is again recommended to certain types of migraine. And anticonvulsants are also having a place in management of migraine, and the available agents include topiramate and levetiracetam. The common differential diagnosis of migraine include chronic daily headaches, brain tumors, idiopathic intracranial hypertension, tension headaches, vascular malformations, hydrocephalus, head trauma, mitochondriopathies, and cluster headaches. So we have to, our assessment should rule out these conditions as well by careful history and examination while we diagnosed migraine based on the clinical grounds. And if you look at the other two common types of chronic headaches, tension headaches and the cluster headaches, there are several important differences by which you can make a comparison between those three. Now, if you take the location, migraine can be unilateral or bilateral, but tension headache is usually bilateral, whereas cluster headache often unilateral. And the quality of the pain, tension headache is like a band-like, non-pulsating, whereas migraine, it's a pulsatile headache. And if you take the intensity, cluster headaches have the severe most intensity, tension headaches have the least intensity, and the migraine kind of having an intermediate intensity of pain. And the headache pattern, tension headaches are usually non-progressive headaches, whereas both cluster and migraine headaches are acute recurrent headaches. And effect on the activities, tension headaches are not, they are not limiting your activity, whereas migraine, often the children stop working because of the moderate to severe pain. And cluster headaches often lead to restlessness, and it has a significant impact on activity. However, if you take the duration, cluster headaches, they are of short duration, last from few minutes to few hours, whereas migraines can last up to several hours or up to 72 hours, whereas tension headaches are of long term and can last up to several days in duration. And treatment of tension headaches managed with non-pharmacological therapies coupled with simple analgesics such as paracetamol and ibuprofen, and also eliminating any trigger factors. Cluster headaches, in contrast, they are short lasting. Some certain, like for example, brain tumors can sometimes present mimicking cluster headaches, so it's important to rule out a secondary cause in children presenting with cluster type headaches. And acute episodes are treated with 100% oxygen with a high flow rate, ideally delivered via a non-rebreathing mask with a reservoir bag. And also these episodes can be treated or aborted using intranasal sumatriptans. And this new daily persistent headache is another differential diagnosis of chronic persistent headache, but we should differentiate it from migraine and tension headache. So it's defined by the presence of intractable, daily and unremitting, so it's never relieved, headache that is lasting for at least 3 months. And it is of abrupt onset, and most of these children do not report of having headache in the past. However, they can share features of both migraine as well as tension type headache. And the intensity of headache is usually mild to moderate, so children can function despite having headache. And it's important because of its persistence of headache, it's very important that you rule out the space occupying lesion by doing appropriate neuroimaging in children presenting with new daily persistent headache. However, it's not either migraine or tension type headache. The pathophysiology is evolving, so we don't know exactly why it is happening, but it's another differential diagnosis of chronic persistent headache. And about other causes of other secondary, if you take the chronic secondary headaches, there are several important causes which we need to assess as well as manage. Idiopathic intracranial hypertension, previously known as benign intracranial hypertension, is an important cause of chronic headache, chronic secondary headache. They usually present with frontal headache. So their site of headache is often frontal, and they can have intractable severe headache. And they have associated signs of raised intracranial pressure. They can have headache precipitated by sneezing, coughing, Valsalva maneuver, and they can have associated tinnitus as a clinical feature. And if you examine them, they can have papilledema. And obesity is a risk factor for benign intracranial hypertension, so you might find an obese child in physical examination, and it's more commonly seen in girls. So if you have a suspicion about idiopathic intracranial hypertension, despite the absence of papilledema, you have to perform magnetic resonance venogram, through which you can suspect. And after ruling out a space occupying lesion, then you can do a diagnostic and a therapeutic lumbar puncture, and then you can get the CSF pressure, and then you can diagnose as well as decompress gradually in a controlled manner, so that it will relieve the symptoms of benign intracranial hypertension. Referral to the eye surgeon is very important. You can use medicines such as acetazolamide also to manage it medically. And if you take the Chiari type 1 malformation, it's another differential diagnosis for chronic secondary headache. And these children presents with chronic occipital headache with again features of raised intracranial pressure. They can have progressive headache, chronic progressive headache associated with neck pain. And also they can have bulbar signs, they can present with stridor, they can present with difficulty in swallowing, and they can have tongue wasting because of the involvement of the lower cranial nerves. And they also can have cerebellar signs because it's located within the posterior cranial fossa. So they can present with cerebellar signs such as nystagmus, pass pointing, and ataxia. And also they can have spinal cord symptoms, central spinal cord symptoms, such as hand tingling or numbness. So in order to diagnose it, you have to do a MRI head and the cervical spine, which can locate the Chiari malformation. And the management include the referral to the neurosurgeon to manage it surgically in those with symptoms and those with signs of raised intracranial pressure. And presence of trauma or concussion, again, an etiology for chronic headache. For example, history of head injury or whiplash injury should be inquired, and should be managed appropriately, including offering psychological support as well as, if needed, by referring to the neurosurgeon. And vascular malformations, including cerebral arteriovenous malformation, is again a cause for chronic persistent headache. For example, Berry aneurysm can present with silent chronic headache. So unless you do a magnetic resonance angiography, you might not visualize it. And remember that it can present mimicking a cluster headache. So if you have symptoms of cluster headache, you may have a secondary headache due to arteriovenous malformation or Berry aneurysm. And a few other causes, for example, prolonged fasting or anorexia nervosa can present with chronic headache. So take a proper dietary history. And vision-related problems such as presence of refractory errors or presence of glaucoma can present with visual disturbances and chronic secondary headache. So it's important to do a proper optic examination, and then if you find any alarming signs, then refer to the eye surgeon for further management. And ENT related problems such as rhinosinusitis, sinusitis, tonsillitis, and dental issues such as temporomandibular joint issues and dental caries can be the underlying cause for a chronic secondary persistent headache. So we need to carefully examine the ENT and dentition, and then appropriately a referral should be made to the ENT surgeon or to the dental surgeon. And psychiatric conditions are also in the differential diagnosis of chronic persistent headache. So children with anxiety or depression can present with chronic headache. So they can also have previous history of long-term headache, disorganized family backgrounds, family history of anxiety, depression, and they will have other clinical features of anxiety and depression, so needs evaluation in line of that, and a referral should be made to the pediatric child psychiatrist for further management. And there are a few other, although rare in our part of the world, but can still be present, and we need to be aware. For example, exposure to substances. For example, teenagers, alcohol dependence can present with chronic headache, and abuse of substances such as cocaine, or exposure to carbon monoxide, or oral contraceptive pill use by teenagers also can present with chronic headache. So we have to inquire such history from teenagers. And substance withdrawal such as opioid withdrawal, caffeine withdrawal, also important to look at. And epilepsy, so children with epilepsy can present with headache as a presenting feature of their seizures, Might need referral to the neurologist and optimization of underlying epilepsy. And several other primary causes such as sleep apnea can lead to sleep disruption and chronic headache. Tumors such as outside of the head tumors, extracranial tumors such as pheochromocytoma can present with headache due to high blood pressure, or hypertension or hypertensive encephalopathy. Underlying liver or kidney disease can present with chronic headache due to uremia or hyperammonemia. And celiac disease in white populations, and vitamin D deficiency, which is very important in our part of the world. Vitamin D deficiency can present with headache, so it's worth looking at. And presence of an underlying anemia, again, it's one of the important causes of chronic headache. So these causes also need to be thought of while evaluating a child with chronic headache. So overall management. So what the family wants is a clear explanation, and they.
So sorry to interrupt you. Those who have, please switch on the mic so it will not interrupt the lecture.
Can I restart, Laksan?
Yes, sir, sure.
Right. Okay.
All right.
So overall, now we discussed about individualized management of each and every course. Overall, what the family wants is, most of the time, these parents or the teenager wants an explanation why they are having the headache. They won't mind if it's a migraine or tension type headache, because they are not, their child is not having a tumor or some underlying primary cause. So we need to be clear that there is no underlying secondary cause to explain the child's headache. So that needs thorough history taking, thorough examination, and appropriate investigation to give them an explanation about the etiology. And then we have to be clear that we have to be clear to the parents that most of the chronic headaches have no underlying cause, so that we don't need to do an exhausting list of investigations to look at each and every cause. And also, we have to acknowledge the fact that this headache is very distressing to the child. We can't kind of say it's all right, or this is migraine, but it is a real trouble. It's going to affect their quality of life. It's going to affect their studies, day-to-day activities, participation at leisure activities, social activities, participation in sports. We have to acknowledge them, and we have to agree with a robust kind of management plan while minimizing the dependence on pain relief medications. Because if you use too much pain relief medication at one point, child is likely to develop medication dependence. So that also can become a problem. So medication overuse syndrome can be, children can develop medication overuse syndrome if they use too much pain relief over many months. So it's again a common treatable cause of chronic headache. So that can maintain your headache. That can be the reason for your headache in a child with chronic headache. So any agent, including paracetamol or ibuprofen, which are used as analgesics, can be responsible for this type of medication overuse syndrome and headache. So we have to give them a clear explanation to the patient, and also we have to formulate a guide as to how we can withdraw the offending medication. So also, when you stop taking that medication over a couple of weeks, child might experience an increased intensity of the headache, but with time, child is likely to improve on symptoms if the child's diagnosis is a medication overuse syndrome. So that's very important part in management of chronic headache in general, of those who are dependent on pain relief medication. And then we have to encourage healthy lifestyles, such as any child with chronic headache, advise them to have regular sleep, advise them to use screens before beds, limit the screen time before they go to bed, and then encourage them to get regular healthy meals, including the breakfast, and maintain adequate hydration, avoiding trigger factors, especially the caffeine, and increasing the time for relaxation. So they are likely to be helpful in any chronic headache, irrespective of the etiology. And then specific pain relieving techniques, for example, stopping overuse of analgesics and emphasizing on alternative pain relieving techniques such as relaxation, lying in a dark room, especially while sleeping, placement of a cool cloth overhead while sleeping, distraction, that's kind of as a method of distraction, massaging, minimizing the secondary gain from headache. So you should not avoid challenging situations because you are having headache, because the gain that can maintain your headache. So that's again an important part of management. And then agree on a graded return to normal lifestyle. Pharmacological treatment. So we can use the pain ladder, analgesic ladder in managing children with headaches. However, we have to keep in mind we should not overuse or regularly use them over a long period of time. Especially opioids are not recommended to be used in chronic headaches because of the risk of opioid dependence. And then neuropsychiatric evaluation and child psychological inputs. So if the child is having associated anxiety and depression, they can be referred for appropriate management, offer reassurance if indicated, and give them psychoeducation, give them adequate explanation about their basis of symptoms as well as the likely outcomes, and then reinforcing lifestyle modification measures. And if needed, the child psychologist and the child psychiatrist can help with offering behavioral and cognitive psychological measures in improving child's headache as a measure of minimizing the use of analgesics. So if if I am to summarize the overall kind of management of a chronic progressive headache, so take a good history, good examination, rule out a space-occupying lesion. If your concern is the space-occupying lesion, without delay, go for urgent neuroimaging. But if a space-occupying lesion is unlikely, then look for possible secondary headaches. So again, take a thorough history and examination and do limited investigation. And if you find the secondary cause, then manage in line of that. For example, if your cause is benign intracranial hypertension, manage down that line. And once you have ruled out space-occupying lesions as well as secondary headaches, then you are left with primary headaches. Then also it's important to rule out certain medical conditions like vitamin D deficiency, anemia, sometimes sickle cell anemia, causing a sinus thrombosis. So it's important to do some basic blood workups and then looking into them and then managing appropriately. So and also once you are left with chronic persistent headache, chronic primary persistent headache, then look at medication overuse headache, and then if it's the reason, then try to treat that. And then once you have ruled out all of these conditions, space-occupying lesions, medically treatable conditions, secondary headaches, and medication overuse syndromes, then you are left with chronic primary headaches, mainly tension type headache, migraine headache. And then in all these conditions, irrespective of the underlying diagnosis, you can encourage healthy lifestyle, including sleep, diet, hydration, encouraging regular healthy exercises and psychosocial support. And then alternative pain relieving techniques such as rest, relaxation, distraction, avoiding secondary gain, and graded return to normal activities. And then psychological measures, treating associated anxiety or depression, and training them on relaxation techniques, improving coping skills, training biofeedback, practicing mindfulness, and offering cognitive behavioral therapy according to the indication. So that is kind of a generalized approach which can be offered to manage a child with chronic persistent headache. So in summary, chronic headache is a common presentation, and most of these is due to chronic primary headache, including tension type headaches and the migrainous headaches. Whether it be primary or secondary, it's going to be very distressing and debilitating for the affected child and the family. So they need a careful assessment by history and examination to rule out secondary causes, and they need a clear explanation about their etiology, as well as how they can cope with the distressing symptoms. And at the same time, while offering neuroimaging to rule out space occupying lesions in children with chronic headache that lasts for more than 2 weeks, it's important to keep in mind that we should not over investigate children with chronic headache.